All right. So just want to say good afternoon to everyone and welcome to our collaborative meeting in November. It will be a pretty full agenda that we have today, but we're also going to go ahead and record the meeting for everyone. So let me just go over our agenda of the day. So we're going to start out by spotlighting a few of our councils. Thank you to everyone who did reach out when I asked for volunteers. Our hope is to give everyone an opportunity to share their work during this and or future council meetings, and hopefully allow some of you to feel comfortable to reach out to one another, connect with each other, etc. And then we'll do some small group discussions to have a little bit of smaller conversations, more in-depth conversations, so that you all can kind of share a bit of challenges, successes, things you've been seeing in your community, how you've been working with your councils to overcome any difficulties you've encountered. And then just to follow up from our May session, we're going to talk a bit about the work that MDHHS has been doing around race and ethnicity data collection. And then we'll close out with a few grant-specific updates and leaving some time for you all to add in questions as you need. All right. So we'll start out with our spotlights. So Ingham, Kent, and Saginaw volunteered, and I wasn't sure who would like to go first out of the three of you.
We can go first.
I see you unmuted, Dana.
Yeah, we can go first. Can you guys hear me? Okay.
Is it just my audio that I can't hear anyone?
I can hear Dana.
Here.
Oh, okay. So that is just me. Feel free to go ahead, Dana.
Okay, all right. Do we have we've got share screen access?
It should be at the bottom of your screen, that green arrow. Can you see that?
Mm-hmm.
There you go.
Okay, whoops. All right. Do you guys see the screen? Awesome.
Yes.
So let me just move the bar down so I can see. And let me get this out my screen too. So hi everybody, I'm Dana Watson. My pronouns are she, hers, and I am here representing Ingham's Health Equity Council, along with Jason Blanks, who's on the meeting too, and I will be passing it to him at some point. And then also Jason, again, feel free to chime in anytime you'd like to.
Okay, no problem.
Awesome. So again, we're Ingham County. We're located in the greater Lansing area and represent greater Lansing in Michigan. And we work together, Ingham County Health Department and Capital Area Health Alliance, as the backbone for our health equity grant funds and the backbone team for our council. So last year, we decided to use the funds we were designated to create a 12-member health equity council that represents people who are or work for BIPOC community members in our area. And what we decided to do last year was we grant some of the dollars out to community organizations or individuals who were doing work to address COVID-19 disparities for BIPOC community members. Alrighty. So our accomplishments for this year Sorry, I got to move my boxes around. There, I'll do that. So our accomplishments for this year included an interest in increasing the number of Health Equity Council members from 12 to adding 3 more, which made it a total of 15. We had discussions with our council about like who was missing at the table as far as representation goes. And so we got feedback from our team like that maybe a doctor could join us, or maybe someone or some more people from our Muslim communities could join us. But anyway, we got their feedback, and then we put the application out, and we were able to seat 3 more Health Equity Council members. Each of our 15 members receive a stipend for their involvement in this process, and our work is led by our Health Equity Council members. So again, Jason and I might present ideas and or talk about and do that background stuff on getting the dollars distributed, but as far as who's going to get those grant dollars and the work that we're going to do, there's full participation and consensus from our Health Equity Council members. We also added staff to our backbone team, which was really great. Last year it was Jason and I, and then we were able to add a Health Equity Council coordinator. And then this time around, we were finally able to add a 4th person who is a programs assistant that I share on my team as well. And so being able to spread out that work has been just, again, so beneficial to making sure things happen on time and that things happen in good ways and that we've got great perspective. Another wonderful accomplishment, and this also came from being able to see, I know some of you all have logos as well for your Health Equity Council. Our Health Equity Council created a logo. It included people adding in their ideas on what it should look like, and us also talking about what a logo might look like to represent Ingham Health Equity Council. This is the logo that we have, and our Health Equity Council members ended up voting in consensus for that to be it. So you can see our wonderful logo there. Very proud to add it to our signatures and work, because we did get questions from our grantees last year. Do you have a logo? And I think it's nice as we spread this work out that people start recognizing the logo and being like, oh, they're with Ingham Health Equity Council. Jason, were you saying something? I'm sorry.
You already said it. You just beat me to it, that we've been adding this logo to everything that we've been putting out to really try and drive interest in, or at least questions around health equity. So thank you, Dana. Go ahead.
Yes, sir.
Mm-hmm.
And so next is some also accomplishments that we were able to do this time around, and that was revise our application process and also our scoring process. This time in our application for the mini grant dollars, we added a direct question about COVID-19 disparities so that we were clear and everybody was clearer on how they themselves speak to the funds going towards addressing COVID-19 disparities for BIPOC communities. We also were able to ask applicants this time for demographics on those that they plan to serve. That was a question we had last time. And so again, just being able to add it to the application and them just straight up telling us was very helpful. And we automated our systems as much as possible. We have a very bright HEC coordinator, technologically wise. And so from creating the survey through Alchemer, so that was able to be seen on an Excel sheet, to him going forward and creating Google Forms so that the Health Equity Council members could score each of the grants. And we would, again, in an automated way, see who scored what, get their scores, and be able to look at them a number of different ways.
Yep. I would also like to just share just on that is that moving to the automated system helped us to remove human error. Sometimes you may get some council members that would either maybe grade very conservatively or maybe use a number system that was outside of the scope of what we had anticipated. So just setting it up in an automated system just made things so much easier for us as we're moving forward. And so if anyone had any questions or any or like for us to kind of show you how we set that up, we're always happy to share the information. Go ahead, Dana.
And so next slide is our successes. We were able to get about 37 applicants. Some people, like we asked people not to apply 2 times. So there were some applications where we took the last one or had some conversations about that. But 37 different individuals or organizations applied for the HEC grants. It was our goal to push the message out that this was available. So we had press releases, we utilized social media. We even had a health equity council member that real quickly, to me, like created a social media post so we could let people know that these grant dollars were available. We emailed former people that applied, but just really worked hard on letting people know that these dollars were available. Other successes is we ended up getting all of the applications fully scored. We used averages to identify the new organizations and or returning organizations that would receive dollars. The averages was based on some missing scores, where if we just added it up, you know, a group would get penalized because for one reason or another, the health equity council member wasn't able to score that application. So in the end, we were able to award, and the messages are going out today, 13 grassroots organizations or individuals that service our BIPOC communities. It's really exciting because this time around, while we landed at the same number of organizations, some of them are returning, so the process will be easier as far as getting them paid and things like that. I'm, you know, this is my second time around, so my familiarity is a lot better too. And then we were able to award at higher amounts, which was a goal. Recipients received up to $16,000, might be 14 or 15,000. And we learned a lot about indirect costs. So that's a success, but it was something that our Health Equity Council member brought up in reviewing the breakdown of where people were going to put their dollars. And so I got to learn things about indirect costs. And again, you know, we're looking to fund program and direct costs, not really indirect costs. I will pass to you now, Jason.
Thank you. So everyone, I'm Jason Blanks, and the plan for Ingham County, we will inform applicants of their award status in the coming weeks. I just did it today, so I'm ahead of the curve. So I've already sent off emails today notifying. I've even had, I didn't tell Dana, someone called me thanking me over the phone. Oh my gosh, it's so great. So I will say, and I always like to say this, but I'm not trying to brown those either, but state of Michigan, like MPHI, this is such a great project because the impact out there is astronomical, and it just gives us an opportunity to really try to you know, target our BIPOC communities and make sure that we are also you know, working with these grassroots organizations to address, you know, disparities caused by COVID. I mean, this is a Christmas gift in itself for those that celebrate Christmas. So sorry. All right. So awardees will be required to have one-on-one meetings with the HEC. We try and do or mimic a lot of the oversight that MPHI and state of Michigan does. We are trying to replicate that as well. We look at that as a best practice. So we're going to continue to do that. We did that the previous year. We're going to continue to do that this year. More frequent communication with grantees. So our Health Equity Council members wanted to make sure that they are in on all those calls with those awardees. And we're trying to always make sure that we are identifying dates and times that really fit within their schedules so that they can be on, or invite those individuals to opportunities where we can have meet and greets. And so we're just going to continue to do that as much as possible, make sure that we are also still just providing the best oversight and resources that we can possibly provide as either a nonprofit organization or a municipality. even when it comes down to, hey, this new grant just came out, how can we work with you? So even looking at the ones that did not get funded through our grant process and still offering them opportunities to still partner with maybe CAHA in some way, some shape or form. And then recognition of our HEC councils, organization, and individuals. And I kind of just touched on it, but really just making sure that we are promoting the great things that are happening, telling the stories, finding ways to share the work that the HEC awardees are doing in a different type of way, either a newsletter or posting on our social media pages or posting on our websites. We try our best to really try and get that information out there. At the end of the year, we always do a recap or outcome-based presentation. So, all right, thanks, Nicole. Yes, and I'm happy to share once again any type of format that I use for any type of newsletter. But anyway, I'm going to stop talking because I need to give time to, or yield the rest of the time to our other presenters. Is there anything else? Dana, you want to take it, or you want me to just say thank you? All right, thank you, everyone. And I'll put my contact information in the chat as always. Well, I know it's probably already out there, but I'll still put it in there anyway. So any questions or comments?
I've got one comment.
Yes.
Dana, you got some help. I love it.
Yes, me too.
If you all want to brainstorm through some ideas of council interaction, particularly with your grantees, definitely let us know. Danielle and I have a few ideas, so let us know if you want some help, and we'll give you.
We'll take it. No, you don't even have to. You don't even have to. No, just tell us. We'll take it.
Yes, thank
Set
you.
up a meeting.
All right, we'll make that happen.
All right.
Thank you very much.
Any other questions before we close out? All right, back
Thanks,
to
everyone.
you. Thank you,
Thank
everyone.
you so much, Jason and Dana. I really appreciate hearing more about the work y'all are doing. So we have either Kent or Saginaw. So, Joyce, yeah. Do you have slides that you would like to share, Joyce?
Yeah, Terry Pruitt, who's on there, is going to be sharing in just a moment. But I just kind of wanted to open up because we have 3 of us today will be presenting, and you given me 15 minutes, so I have to script myself or I won't go over. But I want to say I'm thankful for this opportunity to share some of the work that our HEC has accomplished over this last year. We started off, as many of you did, to expand existing or develop new strategies and prevention resources and services to reduce COVID-19 disparities among at-risk population and people who are underserved. And in our community, we're talking about African Americans, Latino Americans, as well as Native Americans, and we included some others, and you hear about that in a minute. We wanted to improve or increase our data collection for these underserved populations and mobilize partners and collaborators to advance health equity and social determinants of health as they related to COVID-19 disparities among these groups that I've mentioned. But to accomplish these goals, we put a pretty good plan together. We also gave out 10 mini grants. We had 20 applications last year, and we gave out 10, and we're in the process of about to give out some more dollars, but we're in the process that you'll hear that in a few moments. But it was clear that our certain foundational elements had to be put in place first before we could continue on. One of the key elements of our plan was to conduct listening sessions or focus groups among racial and minority populations to gather data regarding COVID-19 and the best way to collect that data. So after many months of training HEC members, developing pertinent questions and protocols, we conducted 11 focus groups covering various numbers, and you'll see those in a few minutes. And we have a final report and a list of recommendations that are going to inform the work that's set before us. And we're meeting right now doing those things. I have with me Mr. Terry Pruitt, who is the president of the Saginaw chapter at the NAACP, and who is a HEC member and a former Dow Corning corporation exec who ran their marketing department. Isn't that wonderful? We have him at our table. And he's going to go over quickly, give you an overview of our findings. We will end with our Saginaw County Health Officer, Chris Harrington, who's also here with us, who will talk about how our findings are informing how our county will infuse the work of the HEC into the overall Saginaw County Health Improvement Plan and the Be Well initiative for Saginaw County. So Terry, can you take it from here?
Thank you, Joyce. And just before I put the presentation up, I just want to say thank you to all of you for allowing us to join you today and be a part of the of explaining and reviewing some of the work that we've accomplished here in Saginaw. As Joyce indicated, I once was a corporate executive, and part of my responsibility for a number of years is running our market research department. So I sort of introduced this idea of the listening sessions patterned after focus groups and training facilitators and collecting this information and doing all the transcribing and coding and capturing the feedback in a way that we can present it to other institutions and local decision makers as they proceed. So I'm going to go ahead right now and share the screen and review a little bit of what that whole exercise has taught us. All right, thank you very much. Can everybody see that?
Yes. Mm-hmm.
Yes, we can see it.
All right, so we also had to go through the exercise of trying to define a logo, and you see that, and you'll see that as part of this presentation throughout. This is really kind of an overview of what our final report looks like. We're getting ready to publish that in written form and put it out on social media and share that with a number of other institutional organizations and leaders throughout this community. The report details the background of how we got started, who are members, the methodology we use to collect the data and the information, and what our key findings and recommendations were. I won't spend a lot of time going through the recommendations, but I will say this on the front end of this presentation, that the listening sessions for us did exactly what I thought it would do: confirm the existence of the disparities, confirmed that there's some cultural competence training that really needs to take place in our community, that we need to upgrade the level of communication between the end user and the service provider. Some things unique about Saginaw, it is a very diverse community, not only from a racial standpoint, but across a number of socioeconomic determinants: income, rural versus urban, age, education, any number of those, and you'll see some of that in just a moment. We were fortunate to bring Joyce on as our coordinator. Joyce is a former mayor, serves on the school board, so is very well connected in the community. I am too, as president of the NAACP. I've been on every board and committee and task force areas at Saginaw County: the United Way, the Chamber Board, the Community Foundation Board, you name it, I've been there. And so, which has been very helpful for a number of us, because we can reach out. We know the institutional leaders. We know some of the people who are trying to accomplish some of this activity and work in our community. And so we were able to do that. There are more than 30 organizations that are part of our council. And you can see the Community Foundation, our school district, the Saginaw Valley State University has been a tremendous asset and support for our work. Great Lakes Bay Health Centers, which is a major provider of health services, Covenant, our Community Action Committee, the Gay Pride Group, Ascension, which is our St. Mary's, one of our major hospital and healthcare institutions, the Mexican American Council. We've got tremendous support, 2 people from the Islamic Center who sit on the HEC. So you can see we've got tremendous diversity with respect to just the makeup of the council. The other thing that I think we're very, very proud of is the fact that we do have, I think, 5 very great grassroots participants who are actual members who attend regularly and offer their input and will challenge the rest of us who think we know it all. We talked about these facilitated listening groups. This is just kind of a depiction of what that actually looks like. Each of the sessions was around 1.5 to 2 hours. And most of them we had 8 to 10, and in some cases we exceeded that. We had 12, 13 people. We had a trained facilitator. All of the facilitators, in fact, were members of the HEC Council and agreed to go through a 2-3 hour training program where we would take them through the interview protocols, and the questions, and they'd have to practice and role play because we wanted them to remain as neutral as possible. Some of them bring a little bit of the bias to the table because they represent organizations that think they have answers to some of these questions. So we spent the time working with them. We did record the information. We had all of the individuals who participated. I think there were about 121 of them across the community, sign consent forms, because when you start talking about COVID and obesity and some of the other issues, you're getting into personal health care information, that kind of thing. We did not have anyone that we reached out to say no, that they would not sign, that they would not participate. Just a quick overview of how all these things came together. We did our research, we did the recruiting of the facilitators, we completed the planning and logistics around where we would conduct these sessions, how we would go. In most cases, we went to them. We had to secure a transcription service that gave us some pretty good turnaround time. Some of these transcripts, when you look at a 2-hour meeting, were 70 and 80 pages that we had to go through and read and extract all the impertinent information. So we had to conduct the sessions. That's step number 2. And you can see that there was a lot of steps to making that happen. And then after the sessions, we completed some coding training for people, completed the coding of all those transcripts, finalized our conclusions and recommendations, and developed a final report. And we just met earlier this week to talk about a distribution strategy, who we're going to give this report to, and how, as the public and our leadership in this community, going to know about this. You can see that these are the 11 groups that we did. We did a group listening session with about 12, 13 of our African-American clergy leaders. We did a session with members of the Saginaw Latino and Hispanic community, the gay, the lesbian, gay, BTQ plus community, which was a very good group that came together. We targeted some socioeconomic disadvantaged citizens in our community. We talked to a large group of retirees and seniors. We included a group with just members of the Muslim community, members, again, of the socio-disadvantaged community, but these were focused on the younger people, this group here. We did a group with just adult females impacted by infant mortality. I think when we look at all the work that we did, this is probably the most dynamic group that we had. Those women poured their hearts out. There were several women in there who directly lost, either in childbirth or after a short period after their child was born, lost a child, and talked about that whole experience and how they were impacted by it. So we did some rural groups also. Who did we talk to, and what do those people look like? I think the real message here is that it was a very, very, very diverse group by gender. 59% of them were male, 40% were female. Many of you might expect that would be reversed, but we got very, very good gender participation on the male side. Ethnicity, 57% of them were African American, but we had 16% Caucasians, we had Hispanic, we had any number of people who identified themselves as multiple race and others. So we covered the waterfront from a diversity standpoint in terms of who actually participated in these sessions. Age also, it wasn't just concentrated in one group. You can see that the largest group was people who were actually after 1970. So that kind of would be the baby boomers, and but we had millennials, we had seniors, all represented in these groups. Income, all over the waterfront, we had people who were on public assistance and didn't really earn any money, or on disability, all the way up to people who, you can see 20% of our people were in that category of, I'm sorry, 25 to $50,000. In the purple, we had people $50,000 to $100,000 who were actually sitting in these groups talking about their experience with COVID, talking about obesity, talking about the issues that we had in front of them. So as we looked at that, we looked at employment status, we looked at education level of these people. So you can see, again, very diverse. We had people who had not completed a high school diploma, all the way to people who had graduate college degrees across the waterfront, very diverse. And then finally, we looked at the size of household and the geographic area of the community, of the county where these people came from. So again, I think the takeaway from all of this is that we really did have a very diverse group of people that we sat down and talked to. So I won't spend any more time with methodology. I think what I want to just make the point here is that there was some rationale to the madness. I mean, we did actually have a plan. We talked to people about how to code. We did the training. We explained to them what that was, and got buy-in on how to do it, and got some people to help participate in that exercise. And so it was not only a rewarding experience, but I think for a lot of people it was very much a learning experience. So let's try to go through some of our findings. The majority of the study participants had significant exposure to COVID. That was one of the issues that we touched upon very first at the very beginning of many of these sessions. What was your experience with COVID? The vast majority of them either contacted COVID, had individuals in their family contacted, and many of them had people who suffered severely from COVID, even up to death, and they described what that experience was. There is a continuing lack of trust and confusion regarding COVID information. I think as we all sit here today, we're getting reports that there are upticks and that sort of thing. When is the edict going to come down that we have to put a mask on, or do some other things to protect ourselves? So you can see that there's still a lot of confusion and just trust in who is providing this information and where it comes from. Many study participants still have major fear of COVID. A lot of these folks that we talk to are scared to death of tomorrow and what it might bring if it's another outbreak. Healthcare professionals, social media, and family friends were the primary sources of information about COVID. We asked a very direct question: where do you get your information from? And I tell you, social media and their peers and family members are right at the top of the list. And so, judge that for yourself, but with social media and some of these family, friends, and peers contributed to some of the confusion that was out there. Many participants experienced mental health fallout from COVID. Depression was a major issue for some of these people. Obesity, study participants associated obesity with excessive weight. That's how they defined it. That was one of the questions we asked. How do you define obesity? Participants indicate that obesity is connected to a range of physical and emotional issues. And the participants suggest that obesity is linked to various social and economic issues. They know that there's some things out there that contribute to people. They may not have the ability to express all of them and define all of them, but they know that they exist. They identified healthcare providers and again, social media as the major sources of information about obesity. When we look at mental health and substance abuse, which was another topic area for us, a significant number of study participants mentioned significant cultural disconnect and communication challenges with their service provider. It's poor understanding of mental health problems for culturally and socially diverse groups, resulting in poor and inconsistent treatment. COVID contributed to increased use of alcohol and social drugs such as marijuana in our community. And people were readily admitting that, hey, I was sitting at home by myself and I started drinking and I started smoking and I started doing all those things that I said I wasn't going to do. Infant mortality. Participants, minority women, mothers identified communication challenges with their service providers for resulting in inconsistent and poor treatment. We have in our report verbatim comments on all of these topics that help support these findings and our recommendations. And we will be glad to share that report to you. But when you read through some of the comments and the statements from these individuals, it will give you a very emotional connection to these people and the issues that they were confronted with. Women in these sessions were describing sitting in the hospital room with a doctor who could not talk to them and give them any comfort at all. Didn't even want to suggest it or tell them the truth about what was going on with their body and with their child. So it was a very, very, very frustrating experience for a lot of them. Participants cited limited or lack of post-trauma counseling. I mean, after all going through all of this, some of these women are 2 and 3 and 4 years past it, but still are suffering emotionally from it and don't know where to reach out for support. Several participants indicated a lack of awareness and available of prenatal education services and materials that they can consult. So our key conclusions, I've kind of hinted at a lot of that already, so I won't spend a lot of time going through this, but our study effort confirms that racial and socioeconomic factors contribute to continuing disparities in this community, especially as it relates to healthcare and mental health services in the community. Eliminating disparities will require a sustained, multifaceted series of actions and coordination and equitable distribution of available resources to marginalized groups in our community. The Saginaw County data indicates that the community aligns with national data trends where we, again, see the disparities, not just in this community and not just in the state, but across the nation. Improving quality of physical and mental health care must include addressing all of the issues that we've talked about here. Some of the key recommendations: expand cultural competency training for our healthcare service providers, local access to quality training toolkits, trainers, and other resources, initiate benchmarking efforts to determine best practices. We talked about conducting an annual career fair and increase exposure and experience for people to be interested in pursuing careers and better improving their ability to provide services to some of the marginalized citizens of the community. Providers must expand community outreach and education efforts. This is one of the things that I want to just make sure we underscore. Identify the right messaging and the right messengers. I think we've got to give a lot more attention to that, because as we listen to some of these people and talk about social media, some of the people that they give credibility to and listen to, it's amazing. And so we really need to spend a whole lot more time in creating the right messages and having the right messengers in our community to deliver those. Healthcare providers must continue to build and sustain community partnerships. This has been a great exercise because I think Christina and the county health department, our hospital systems, A number of other key institutions have connected with the Health Council, and I think we really, really have created a solid foundation, but we've got to be able to continue to build it and sustain it in our community. We have over 30 people on our Health Equity Council.
And Terry, that's a good segue for Chris to come in right now,
Yep.
because I think that she will, yeah. Chris, where are you? There she is. Chris Harrington is our Chief Health Officer for Saginaw County, and was happy for that she would take time and come and really give it from her perspective about how all of this fits into what our community health plan is. Chris?
Thanks, Joyce, and thanks, Terry, and good afternoon, everyone. I just wanted to sort of underscore what Terry was just talking about in terms of some of the recommendations that are coming out and how important we want to make sure that this huge lift and effort by the Health Equity Council really takes hold in the health improvement planning that we do moving forward. It's really the strong leadership and the connection and the commitment of the entire Health Equity Council, but particularly Joyce and Terry, that really have led this effort to be really organized with the council and provide that strong level of leadership. I think is really attributable to the success of what we've seen of the council so far. And I think their continued commitment to really peel back the layers, talk about health disparities through a new lens, as we develop strategies. So we did our community health assessment last year, and we've been developing our community health improvement plan around those 3 priority areas that the focus groups were asked. So maternal and child health, mental health and substance use, and obesity and related chronic disease. And what we want to make sure is those findings and those recommendations really get intertwined and enveloped in to any of the strategies. We have actually 12 of them that we'll be undertaking as we move forward to improve health outcomes in this area. So our Health Equity Council will be involved in those strategy groups. Various members of the council will continue to be involved. Persons with lived experiences in those groups, particularly as he was talking about infant mortality and maternal and child health, and our strategy maps around implicit bias trainings, about sort of reaching the unreachables. We talk about education and outreach and developing the right messengers for our population to hear, to listen, to engage with the interventions that we hope to develop. So I really want to applaud their efforts and the work of the Health Equity Councils across the state, because I think this is super important work, and it really is so instrumental to making sure that we look through the lens of equity as we develop these strategies and interventions to improve health. So thank you, guys. That's all I have.
Thank you, Danielle.
Yeah, thank you so much. Y'all have really done a lot for the community and to really ensure that you move forward in a way that centers them and centers what's important to them. I just want to give, maybe 2-3 minutes if anyone had immediate questions. Otherwise, I'm happy to share this team's contact info with anyone.
I have a question.
All right, Ann.
I was wondering, and we came across this too in Ingham County. There was this STI surveillance report that I was reviewing that the EPI team had created, and they were talking about gender identities. And so I was wondering if participants were able to were only asked to identify as male or female.
We made sure that that did not happen. Terry didn't show you a part of that, but he could have showed our data collection sheet. Very comprehensive. It was open. You could say whatever you really wanted to say. We made sure
those pie charts that you saw that I put up on screen, that came directly from those demo. Every person who attended one of the sessions had to fill out one of those at the very front end. Who are you? And we gave them those options. No problem.
Well, and I we'll come across the part where sometimes when you're reporting, they are only capturing male or female. And then there's also the suggestion with this STI report was just that they acknowledge that there are other identities and why they're only reporting on male and female, but it's good that to hear too, you know, that participants are able to identify, you know, with their gender identities. So thank you. That was my only question.
Thank you for that.
All right. I'm gonna pass it over to Brian. And I think
Thank
Olivia.
you,
as
Terry and
well.
Chris.
All right. Hey, everybody. Hopefully my screen will show here. My name is Brian Hartle. I work as the director of our Center for Community Health Strategy here at the Kent County Health Department on the west side of Michigan. Thanks for having us here today to talk about our Health Equity Council journey. We always start our meetings with our engagement guidelines, and this was really important for us to do at the beginning of our Health Equity Council journey. We have a facilitator who engaged our membership in identifying how to create a brave and safe space. And so these are just some examples of what we always talk about when we start every meeting in terms of our guidelines and steps to support a brave space. And we really use this as kind of a first consensus building activity with the group. When we first met, we brought a lot of people together from different walks of life. And so it was really important for us to do this and kind of understand how we're going to work together as we move through the last year of the council experience. What we did, kind of similar to what Saginaw did, is we really focused our Health Equity Council efforts on building upon the partnerships that were established during COVID-19 response, and really using this as a way to improve our community health needs assessment and community health improvement plan process. As many of you probably experienced with these things, you bring a lot of people together, ask them a lot of questions, gather a lot of data, analyze the data, send it out, and you see everybody kind of scatter, you know, like mice into their different community health improvement plans, all the different health partners and whatnot, take their plans and run. So we have a pretty big population here in Kent County. We have 3 major health systems, a rehabilitation hospital, and a mental health organization system. And so they typically all take their data and create their own community health improvement plans. And so oftentimes the data is not representative of our populations. We gather data that's really skewed towards older or well-educated populations. And what we really wanted to do with this is really create a system in place to gather community voice, be more inclusive and representative of our populations, really align the health improvement plans that come out of this process, and be more responsive, have the systems be listening to the community voice and be more responsive to those needs and priorities identified by our population. So in effect, we created these goals for our Health Equity Council. The first one is really what we focus everything on, is just that community voice and engaging that community voice in every step of the process, from data collection all the way to implementation of strategies and funding opportunities to improve our health in the community. So that's first and foremost. The second part I just talked about, bringing those systems together to really improve communication, align efforts, and really bring efforts or support and resources to the table, and then ultimately trying to build trust with the community and also build trust between organizations, because as you know, people and organizations don't always work well together when there's competition for dollars and things like that. So that was one of our main goals, is to help improve that trust between organizations. So our community voice group, that's our main group of our Health Equity Council. We've had some of these partnerships engaged during COVID, but really wanted to make it as representative as possible across the county. So we have several different representations or representatives from community-based organizations who serve the refugee population. We have 3 of those. Obviously, the Latinx and African-American communities are there. Asian Americans, Native Americans are represented, but we also expanded it to obviously the LGBTQ plus population, as well as gender and disability. So we wanted to make sure we included all voices at the table, as many as we could. So we have these representatives from the community-based organizations. In addition to that, we have 8 community members who are more representative of geographic areas in a community, specifically zip codes of high social vulnerability. We also have a system or a network of community connectors and navigators that we established throughout COVID that represent different populations in Kent County, and there's 12 of those. And so we have about 30 to 35 total representatives on our Health Equity Council that meets once a month. This is our initial structure that we put in place for the council. As I mentioned before, the community voice group meets once a month. Sometimes we meet more than once a month, depending on what we need to talk about and decisions that need to be made. So that's really at the top quadrant there. The bottom two quadrants really talk about our systems level partners. So the healthcare systems, the community stakeholders, including businesses and academia and government, other community-based organization representation. That systems level group, our initial idea was to have that come together quarterly and really hear from community voice, hear the activities of what's going on in that quarter, and really be responsive to those needs and see how they can support what the community voice group had identified in that process. And then that upper right-hand quadrant was the action teams that really take the work forward and identify ways to implement strategies to affect change in the priorities that were identified by the council. And then at the bottom there, you can see convening support, or the backbone. Our Kent County Health Department staff is involved. We chose not to have one position as a coordinator. We chose to kind of split it up between 6 different people in our Center for Community Health Strategy, because this is what we do, this type of work. And we didn't want to be bound by grant funding that would stop this work if grant funding stopped. And so we ended up kind of sprinkling it between different staff here, so we would really engage this work and continue it if grant funding was not available. But we also included our 2 organizations that represent our major populations here in Kent County, the Grand Rapids African American Health Institute and the Hispanic Center of Western Michigan, to engage their voice to make sure that they were involved in that convening support or backbone group as well. And that group meets once a week to really drive and guide the activities of the council, set agendas, talk about what we're going to discuss in our meetings, and really coordinate what's going on. So we really were ambitious with this process. We basically did a rapid cycle community health needs assessment and improvement process over the course of the last year. We started back with team building, as I mentioned before, presenting data to the group. We identified really a lot of issues with gaps in data that people didn't see themselves in the data. So we obviously wanted to make a difference there as we move forward in our data collection process in this next cycle of CHNA. We did brainstorming and prioritization of needs in our community, really moved to that actions team phase in February and March, and then the mini grant process, where we funded the community partners to carry forth efforts to make change in those areas kind of in April and May. As I mentioned, we were really ambitious. We didn't get that done. We were really happy and pleased that MPHI and MDT HHS gave us a little bit of an extension there to finish our mini grants off through the summer and finish those off at the end of September. So that's kind of our process that we took. And then this is just what we did in our storyboarding session. I think we did that in December of last year, where we just asked people to brainstorm about impactful areas in their community, what impacts health and the communities that they represent. We had 13 different major areas that were identified, and then a bunch of subcategories that were identified. We went through the whole prioritization process, the dots and all that kind of stuff that you've all done before. And really it came down to housing and mental health, and we kind of had a little more debate around what to focus on, and mental health was really the one that came to the forefront, and that's what we focused our efforts on over the course of the past year in our Health Equity Council. As we had further discussions about what impacted mental health in our community, we really identified 2 different areas. So one was around stigma. Different communities had different stigmas around mental health and what they saw as the need for mental health and services, and how people were viewed if they had mental health issues or sought support for their mental health issues, and also access to services, and so or support services. And so that was one major area that we identified. We also heard a lot of stories about how community safety impacted mental health of our communities who live in Kent County. So one was around interactions between police and community, feelings of safety, walking down the street and not knowing what's going to happen if I'm going to get pulled over by a police officer, and how that interaction is going to go if I do indeed get pulled over by a police officer. And also we had youth representation on our council as well, and we heard a lot about how kids don't feel safe in their schools, about bomb threats and other things, shootings. So we really focused our efforts in our action teams around these 3 objectives. And so we have 3 action teams that really focus on these 3 objectives that are all around mental health, but are kind of split up between stigma and access, and then community safety. So our mini grant process, we started that with focusing on just providing mini grants to those organizations who are involved in the Health Equity Council, as well as some, geographic locations or like neighborhood associations and things like that that were connected to the council through one of those community members or community connectors or navigators. And so we initially brought, I think, 11 different, we received 11 different applications for that funding. We ran into a little snafu with our county purchasing department. We had a little bit of different idea of how this was going to go. And we needed to do an RFP because that needed to abide by our county policies, to do the RFP countywide. So we ended up releasing an RFP after the fact. And then we gained 4 additional applications from community-based organizations down at the bottom there on the right-hand side: Puertas Abiertas, the Diatribe, Boys and Girls Club, and AYA Youth Collective. So they responded to our RFP. So we ended up having enough money to fund all 15 of the applications that we received. So we had a process in place that, as Ingham County did too, to have community members and Health Equity Council members be involved in that selection process, but we didn't have to use it because we had enough money to support all of them. And these mini grants were $10,000 to $12,000 each. And we did, however, have the council involved in talking about accountability and how we would assess the success of each of the mini grant applicants. We ended up working with our evaluator. We brought an evaluator into a third-party evaluator to write or create outcome measurement outcome reports for all of the mini grant awardees, and to look at what their outputs were, their activities, their lessons learned, and the like for them as well, to kind of address that accountability issue. One of the things that we were able to do with this is we had so many people focused on mental health and focused on mental health first aid training. And they wanted to get people in their communities trained in mental health first aid. So we were able to use some additional funding or different funding from the Health Equity Council to bring in a national trainer to certify 16 individuals from Kent County to be mental health first aid trainers. And so those were representatives from all the different organizations that we had as a part of the council. So Bethany Christian Services, Treetops Collective, Booties Community of Michigan, Hispanic Center. So now we increased our capacity and increased the diversity of our mental health first aid trainers here in Kent County to really bring those trainings out to their respective communities to help hopefully impact the topic of mental health that was addressed in the Health Equity Council. As I mentioned, with a evaluator, the third-party evaluator, we did have them do a process evaluation as well, in addition to the outcome evaluation, as I mentioned, for the mini grants. So we heard a lot of good feedback. We had a group that was pretty agreeable, that they were heard, their voice was heard, they were proud to tell others that they were part of the Health Equity Council. They participated and they strengthened relationships and built relationships within the community. It was a diverse membership. We were able to secure additional funding, and I think that was a big part of this. So in addition to the MDHHS and PHI funding, we submitted applications to a local funder, as well as the Health Endowment Fund in Michigan, and we were able to bring in more money to support the work of the Health Equity Council. So that was great. They were all worried about sustainability, and we kept on saying, we're working at it. We're trying to get more money. So we're pleased with that. And then they really appreciated the process of the RFP and the mini grants, as you all have, I'm sure, experienced. That low barrier process to apply for funding, as well as that being unrestricted dollars to do what they felt was best for their communities and to make an impact on their health. Some other things here, but I want to focus on the opportunities for improvement. So one of the things that we heard a lot about was that, I'm just one person. I can't really, provide the feedback on my entire population that I represent. And so that one, first one there on the opportunities for improvement, we've really heard that we need to expand our impact and those who we involve in Health Equity Council. So some of these things will be talked about as in a future state. And then one of the big things we've heard about is really use the structure and the partnerships that we've built to really improve that CHNA ship process as we move forward. So we're going to talk a little bit about that in our next slides. So our CHNA, we're going through the cycle this year, the 2023 cycle of our CHNA. The last one was done in 2020. And so the community survey was really an area we wanted to target and do better at, as I mentioned before, really increase representation and inclusiveness of that survey. So we had it open for about a month. We had it available in English and Spanish online. We were able to translate it into 4 different languages and have that in hard copy form. And what we did was we contracted with our partners to distribute the surveys. And so many of those were Health Equity Council partners. And again, this was not Health Equity Council money per se. It was some money that we had set aside for our CHNA that we used to really provide them each with stipends. I think we provided $2,000 stipends for them to get up to 50 surveys completed among those people that they represent in the population. And so we provided them with organization-specific survey URLs. So they would promote the survey and have them have the population that they serve use that URL. So we're able to gather information specific to that organization. So we're planning to create summary reports for those populations specifically and those organizations specifically, so they can take that with them and utilize that for grant funding or whatever they want to do as they move forward, to have a data specific to those populations that they serve through their organizations. And so on the right hand side there, the organizations in bold print at the top are those that have some sort of connection to the Health Equity Council, and those at the bottom were just others that we also contracted with to help get that survey out. One of the big things is we, getting better representation in our CHNA survey. So we doubled the number of responses that we had from our 2020 survey, a total of just over 3,500. Before we would get mostly, 63% of our responses in 2020 were those who had a bachelor's level or higher. We made it more equitable, or achieved more equitable distribution this year, with just 51% of those with a college degree. It wasn't as good as we wanted it to be, but we definitely increased the distribution there. And then really the demographics was where we were really pleased with what happened. And not everyone filled out the demographic section. As you can see, 2,500 people filled out the demographic section. Oh, I think that's my watch talking. But we increased participation across the board, our Asian community, our African American community, Latinx community. And then one thing that we didn't really gather in terms of our 2020 survey was people's status, their LGBT status, their immigrant or refugee status, disability, veterans, formerly incarcerated. So we gathered that this time, and we got a pretty good representation from some of those populations based upon those partnerships that we've utilized to distribute that survey with those organizations that were contracted. The next phase of mini grants, we're planning on doing that again with this next round of funding, both with the MDHHS funding and the other pools of funding that I mentioned. We're going to expand it this time. Last time it was really only open to mental health and community safety. We just did our prioritization for our CHNA after the data collection was done, and we actually had one prioritization session that was just open to Health Equity Council members. So they were the ones providing their voice on the priorities. And so this next round of mini grants is going to be open to both the mental health and community safety, as well as any additional priorities that are identified through the CHNA process. We're only going to go through the Kent County Purchasing RFP process. We did it last time. There were some issues, as I mentioned, but we're going to only focus it on the RFP through the county this time. We heard a lot of feedback last time about the process of contracts and the confusion around contracts. So we're going to have more training this time around the county's process in terms of contracts. Last time we kind of let them just go with it and had one check-in sort of towards the end of their mini grant. Now we're going to have monthly check-ins with them to really make sure that they're going along well with what they're trying to establish, and then also meet some of the demands and requirements of the funding. And then obviously we're going to engage the community voice members, because we anticipate having more proposals this time, with opening up to a broader audience and increasing it to the CHNA priorities as well. So having those community voice members be a part of that, hoping to avoid any conflicts of interest, in terms of those people who would who apply versus those who are members of the panel. So we have to work through that a little bit with our county purchasing department. And then we're going to do two rounds of funding. So we're going to use the MDHHS MPHI funds for that first round, hopefully get that done February, April, May timeframe. But we heard a lot that people or organizations were interested in doing summer programs for youth and things like that. So we're using our additional pots of funding to do a second RFP to do June through September projects through the mini grant process. A little bit about how we're going to change this. This is kind of going back to our initial structure. So as we move forward, as I mentioned before, to kind of expand the community voice from just those 35 participants who are on it, we're going to try to hold community conversations. So we're going to have those members really go out into the community, host essentially focus groups or conversations within their communities to really gather more information, gather more voice around strategies, ideas, give us feedback about what's going on in those communities as a better way to really increase capacity, increase voice in our Health Equity Council. The systems level group, it probably didn't work as we expected. We had a great turnout at our very first systems level gathering, and a lot of people there. And as we went quarter to quarter, it really dropped off. And so we're going to kind of change the way we engage our systems level partners. We're going to create an advisory board. And as you can see here, we're going to bring together academic partners, healthcare payers, insurance companies, public health, government, healthcare systems to be involved in that advisory board that will meet on about a quarterly basis. We'll also have 2 community voice members who will go through a selection process from that community voice group and to be a representative of the community voice group on the advisory board. And we anticipate this group meeting on a quarterly basis. We will also have an annual health equity conference. So instead of having those quarterly meetings, we'll do one health equity conference meeting, and this is scheduled for May of next year to really bring all the systems level partners and really bring together different aspects of health equity that's going on here in Kent County. And then with our convening group, we're looking to expand that, breaking it up a little bit, and not just one group that's meeting on a weekly basis. We're going to kind of break it up into separate groups. So focusing on data evaluation, communication, other things that we need to do, and then come together as a convening core group once a month to really report back on what the separate groups are working on around these different topic areas. So that's going to change a little bit. We're planning on kind of kicking that off after the new year in January to really break up and really expand some participation, because we always kind of felt odd about having the health department and the 2 organizations, Grand Rapids African American Health Institute and Hispanic Center, being in that core convening group. So we're really trying to expand representation and participation from other members of our community and other organizations in those different working groups that we'll do and implement after the first of the year. This is just a real brief timeline of what we plan to do, and this kind of gives you a summary of all the things that we talked about. So this community voice group meetings will continue to meet on a monthly basis. Action teams will meet on a monthly basis. This community conversations hopefully will start next month. Advisory board, RFP process, mini grants, and then the conference at the end of this funding period in May. And I think that's it. This is just a picture of our last year. We gathered at a local hotel at one of our meetings, and this is just a picture of our community voice group. And there's my information down at the bottom if you ever want to get in touch with me about what we do and what you do, and share information and knowledge about our Health Equity Council. So that's it for me. Danielle, pass it back to you.
Thanks so much, Brian. This was awesome. I really enjoyed hearing about the work y'all are doing and just how you've really thought so deeply about the different levels and how each of us play a role in that and how we can go forward to really support our community. So because we are running a little tight on time, I'm not gonna leave space for questions right now so that we can have 5 minutes for a break. So we will see all of you back at 2:20, and then for our team, if you could just stay on for even just 1 minute so we can talk about the breakout rooms really quick. That'd be perfect. Sure. I'm gonna do that. And then I will share my screen again. As folks trickle back in, if you want to throw in a reaction, let me know that you're back. That would be cool. Or if you are so excited to come on camera, that's fine as well. Right. I'm thinking we can start to move into our next part here. We had to do a little bit of pivoting, but we're still going to do kind of some small discussion groups. Originally, we had particular discussion questions, but the chat seemed pretty active and your presentations were so robust and really intriguing. We wanted to give folks a chance to engage with each of the groups that have presented today. So Ingham, Saginaw, and Kent, and either, share some of the insights from the work that you've done with your councils that parallels, or ask questions if you're facing similar challenges, and sort of do some peer-to-peer sharing. We'll have about 12, maybe 15 minutes for this part. We'll just kind of skip across all of these things, but I'm gonna open up some breakout rooms. If you haven't used the breakout rooms before in Zoom, along the bottom, there should be the option once the room's open to select your breakout room. And as you do that, you'll be able to join, and feel free to, if you want to switch between rooms or stay in the same room, that is totally fine. But that is what we will kind of do for the next 10 to 15 minutes here. Wait, let me see if I can open these. You should. Be able to select and join a room, and then I'm blinded by this one. If folks have questions or running into difficulties, please let me know.
Danielle, who do you want us to, where do you want us to go?
Go where your heart shines, and then I'll go after. It doesn't matter.
Okay.
So if you
All
want to
right.
go to 1, Laura to 2, and I'll go to 3, that's really
Okay,
fine.
sounds good. Monique, could you start at 3?
Yep, no problem.
Carrie, Shoni, Lindsay, is there a particular room that I can help you navigate to?
I think we're deciding which one, so we're dividing and conquering which room we're going to go to right now behind the
Okay.
scenes.
That's fine. And then Dr. Pruitt, I assigned you to Saginaw, but if there's another room that you're interested in, I can move you to 1. Dr. Pruitt, can you hear me?
Danielle, he looks frozen.
I think so. And then, Joyce is all set. So Bree, you should have co-host capability. I'll let you lead it, and I will go away. Carlin, Renisha, Clayton, feel free to join different rooms if you're interested in learning more. Or you can take this 10 minutes or so to kind of relax, get some water, whatever you need.
Thank you.
Yeah.
And Danielle, before you go, so did you already set your timer?
Yeah, it's automatically set. It's counting down.
Okay, so would you like for me to broadcast any messages to any rooms or, okay.
It'll automatically close, and it should notify us that it's closing before. And there's like a I think I did 60 or 120 seconds. So there's a lot of time to wind down.
Okay, well, message me if you need any TA or anything, okay?
Okay, thank you.
You're welcome. Hi, Tawana. So everyone has joined a breakout room. If you would like to learn more about the councils, you can select a breakout room that you would like to join, or if you would like to hang out here, that's fine as well. But I saw that you had just connected again, so just to give you a heads up.
Yes, thank you. I was having technology issues. I'll join a breakout room. Thank you so much.
You're welcome. Hi, Renisha.
Hey, Bree.
How are you?
I'm stressed. I'm in the middle of writing this letter for Kim, and she's like, she needs it to right now. So
Oh,
trying to get that together into
okay.
present here.
I saw your email in regards to feedback. I didn't know if, like, I already had my message kind of drafted, and then I saw that everyone's getting the feedback, and I didn't have much feedback to give. I actually didn't have any. So that's why I haven't responded. And then I was just gonna let you know those who are actually working on something to give feedback. But if there's something you need from me directly, just let me know.
Yeah, I think I just need you to send it out when Brenda says it's okay. I know
Okay.
I don't think she working today.
Oh, she's not. Yeah, she's not in today. She's working, but she's not working, like she's working out of the office, if I'm not mistaken. And then I know she will be out next week as well.
Well, I know she wanted it sent out, so I guess we could just go ahead and send it out because we were supposed to send it out tomorrow, and if
Okay.
she's not gonna be here, then yeah, she wanted
Let
it
me
to
make sure that she will, let's see, because we want to make sure we get her final okay beforehand. So I am
yeah,
going to pull up her calendar.
because she wanted it to be sent out before Thanksgiving because we'll be gone Thursday, Friday. So
Let's see. Okay, yes, she is. 1 second today. Okay, so she is right now in a private meeting. I would just send her before the day is over with, just send her an email and CC me on it. And then if she wants it out before Thanksgiving, let's see, next week. Okay, yeah, so she will be out all next week. So just send an email, and then if she doesn't respond by close of business, I'll have it out first thing I'll have it out by Tuesday because I'm not here Monday, but I'll have it out Tuesday just in case, because I know sometimes even though she's out, she will still message us, or at least I get messages when she's out. So, yeah,
okay,
that way, just in case if she wants to look it over or something, I don't want to send it out and then she decides that she has more feedback, which I feel like it should be okay, but just the extra layer of protection and just in case. So
yeah, I addressed all of her qualms that she
okay,
had, so it should be good to go. But you're right.
okay.
I did forget that she was going to be out today, so she won't be back until the following week of like the 30th.
1 second, let me check. She won't be back until the 5th.
Oh yeah.
So, yeah, I would just send an email to her today. She doesn't respond or send me feedback, then I'll go ahead and send it out. And we're sending it, just correct me, like we're sending it out to all of our partners, internal and external partners.
Mm-hmm.
Okay. Well, I'll send it directly from the OEMH email address.
Yeah, that's what she wanted.
Okay.
Thank you.
You're welcome.
Great, welcome back. I think rooms are slowly closing on everyone. Great. So as you all come back, and there's anyone that really wants to drop in the chat or to share something that they really enjoyed or learned or talked about during their breakout, feel free. I think we're slowly getting you all back.
We had some great conversations.
Yeah,
Yeah, it was really good.
good. I hope that folks were able to exchange email, addresses, contact information so that you all can connect offline. If that didn't happen, always feel free to email me. I have everyone's email address, so I can easily get you all connected and help to facilitate any future meetings or anything that you really need. But just wanted to give folks the chance to connect. All right. So we're gonna give you all a brief update on the work that has been happening around race and ethnicity data. If you were here for our May meeting, we talked a bit about MDHHS's effort to work through data collection standards. So the Office of Equity and Minority Health, along with the Legend data team, have come together to identify two objectives to really focus their efforts. So they really wanted to improve the ability to identify those disparities. So the best way to do that is make sure that the options that folks have and select that represent themselves best, and then to thereby improve the delivery of MDHHS programs to racial and ethnic populations. This has been the timeline that they've been working with since March of 2023. And as you see, we're really smack dab in the middle here of, collecting that feedback, getting ready to analyze some of that feedback soon. So having different community conversations, as well as there's a public comment form that we've released, and we'll share that link with you all as well. And then we've had already 3 of our community conversations. 2 were with the specific racial and ethnic populations that we serve within the Office of Equity and Minority Health. So Black and African American, as well as Middle Eastern or North African descent, as well as we hosted one with the Public Health Administration at the state of Michigan. That conversation primarily touched with epidemiologists across various areas in MDHHS. And then upcoming, we will have 2 more race ethnicity specific conversations. So one that we are hoping to reach Asian, Native Hawaiian, or other Pacific Islander folks, and then a Hispanic or Latino, Latinx conversation. These will be virtual conversations, as well as the general public conversation as well. And so those are the dates. We have the RSVP links that we'll be sending out to you all, with kind of the ask if you can share with your partner organizations if that is something that they would be interested in participating with. And then lastly, complete our public comment form. So if folks aren't able to make one of our virtual conversations, we did want to have a public comment form that was available for everyone to complete. And we'll be sharing that link out. If you so choose, you can scan the QR code that's right there as well. but we will be compiling the information that we get from our public comment form, from these community conversations, in order to create those recommendations that were shared in the timeline. So those recommendations will be put forward, shared with the Public Health Administration, and hopefully with their help and support, implementation and planning for implementation will take forward. If you're interested in learning more about this work, feel free to contact the team listed here who's been leading the work. So our OEMH leader, Brenda Jagaday, our epidemiology coordinator, Jasmine Hall, and our health disparities epidemiologist, William Marshall. And their email addresses. They're happy to answer any questions you have about the development of the data collection standard, how that works, and what that means for future surveys that we may see coming from the state or organizations that receive state and federal funds. And then I wanted to go over our kind of grant updates. A couple key dates coming up. You'll receive the calendar invites for our collaborative dates, but we'll have another in February, and then our last one at this point in May. And so those are just the dates and times. Those will be on Zoom. And I wanted to also share one of our upcoming TA offerings. So we have been able to incorporate the feedback we heard from many of you who took our Health Equity 101 training, that you wanted something that was more in depth, something that more put health equity into practice. How do we deal with the stickiness? How do we move forward and apply it in a meaningful way? So we took some time and developed the Operationalizing Health Equity workshop. This will be a 90-minute workshop aimed at helping participants understand and operationalize health equity in a variety of ways. It'll be rooted in frameworks and language and tools that will help you as participants understand how to promote equity in your work. There's many ways to do this, but in this session, we'll focus on narratives, oppression, and systems, and how they impact who we are in a relationship with how it influences our ability to advance health equity. And so just a little bit of details about the workshop. It will be open to you as the backbone staff that primarily support the work of your council, as well as open to your council members. We can accommodate roughly 30 to 35 people per session. All of these sessions will be held via Zoom, and we will do registration links for those. We don't typically record these workshops, primarily because of kind of the content that can be in a health equity training, where many folks are sharing either personal or sensitive topics. So these will not be recorded for later viewing. I know that is sometimes a question, but these are the 3 dates we have identified now based on the survey that you all took, and kind of what were the most popular response choices. If we do fill up these trainings and have a need to identify additional dates, we can work through that. Or if you say, we definitely have 30 people on our council who would participate in that training, then we can just offer one specific to your group. Wanted to also welcome our new evaluator. I wanted to give our new evaluator, Carlin, a chance to say hello to folks. I can read the spiel from that I wrote for you, but if you want to talk, feel free, Carlin.
Hi, everybody. Sorry for the glare. I'm trying to decide if this is just like a this week daylight savings time, or if I need to move my whole setup. because this is every afternoon. But I am Carlin, and you might be hearing from me more now in place of Shiaru. She is still here and supporting the project, but I'm excited to come on and bring my experience in evaluation with me. I have my master's of social work, so my background is more in community organizing and community-based mental and behavioral health supports, food systems, all of that. So I'm excited to be involved in this project.
We're super excited to have you, Carlin, and excited to do more evaluation activities. I don't think evaluators hear that enough, but folks here are really excited to share the story of their work and to highlight what they've done for community. So that means we probably have more eval activities coming up. So we have 3 that we see on the horizon is our success stories, doing our eco maps another time, and then rounding out with our sustainability plan. So the guidance for these activities will be to come, but just wanted to kind of highlight what we have coming up down the road. Here. It's your slide, Ashley. Oh.
Yep, I wasn't ready. So yeah, the good slide, the funding information. So currently, you all know that you are funded through May 31st of 2024. But as we've mentioned to you before, we are constantly looking for additional funding opportunities. We have been successful to some degree, but we definitely need more support. You are going to get a lot more information as we move forward with what some of this will look like for you. But our PHA, our Public Health Administration office, has received a CDC infrastructure grant. We did get some funding support for the councils as a part of that grant. What that is going to look like for you in particular, we can't answer at the moment, as those funds have not been allocated as of yet. But good news is we do have a little bit of additional funding support so we can continue this work. I just, we know we need more, but we do at least have something. So having something in hand is better than nothing in hand. So we will give you some better updates about that as soon as we have some actual tangible things we can tell you. But this will give you some additional support and some additional timing. So we'll let you know once we get everything squared away what that looks like. Additionally, not to put Casey on the spot, but I know Casey's here. Casey, can you come on camera real quick and say hello? So Casey, we've been working with as well as a part of the cardiovascular health team. So everybody meet Casey. You're going to see Casey more in the future. We have signed on to a grant with the cardiovascular team, which is also a CDC grant, number 2304. And as a part of this grant, there will be some work for some of you all in terms of helping to build some multidisciplinary learning collaboratives. So you all basically already have some learning collaboratives. And so our friends in cardiovascular thought it would be really cool to see if we could sort of expand what you all are doing with some of the efforts that they're going to be looking at tackling. So specifically, they're going to be looking at sort of prioritizing some support around specifically like hypertension, high cholesterol, stroke, and sort of how some limited access things are impacted there, as well as so social outcomes in terms of like racism and how that can impact cardiovascular health. So again, more to come on what that grant looks like and what we'll need you all to do or how you all will be involved, but wanted to get a chance to mention that to you and have Casey say hello. So you'll see Casey more in the future as we keep going. So excited to share those things with you. We again are still working because that isn't enough, but we at least have something in the hopper and we're excited about that. There is also a potential additional NCE opportunity. We met with Marie, our program officer, a couple of weeks ago. There is some interest in allowing the work to continue at the federal level. We had to submit an intent to apply for an NCE should it become available. We did that. We have turned in all of the documents that we were asked to do. We are waiting to find out what's going to happen in terms of the legislation. NCE, yes, is a no-cost extension. So we do need to wait and see what that looks like. No cost obviously means no money, so we won't have the kind of funds to give you that we had with the original no cost, but we're working on what that might look like in terms of being able to provide some additional support. So again, as soon as I know, you'll know, but I wanted you all to kind of understand what we were working on in the background. We've got a couple other things in the hopper we're working on in the background as well. But we want to make sure that you all know we are definitely doing our side of trying to keep this thing going. And so that way you can all start to think about planning, you know, what this might look like long term. So you don't have to, you know, get too excited just yet, but we should definitely be excited because we're moving in the right direction. So we'll kind of keep you posted as, like I said, we get full details on what it's going to look like. We have secured that infrastructure grant funding, and we have secured the cardiovascular funding. So we do have that in-house. We just have to get through the appropriations process and all that to tell you how we're going to spin that down. So good news, but not the great news that we're hoping for, but we're still at it. So we'll keep the party going. Next slide, please, Danielle. Do we have the there we go. We wanted to share with you all, Danielle and I just got back late last night from Atlanta. We've been at APHA since Saturday. We flew out Saturday. And so we just got back late last night, but we presented at APHA about this work. And so we definitely wanted to share with you all that we were able to talk about this work on a national level, which was really cool. There was a lot of interest from people in what's happening here in Michigan. We made quite a few contacts that are interested in sort of finding out more about what's happening and possibly connecting with some of you all individually, but also with some of us as a whole. So we wanted to definitely share that with you. It was a really, really, really great opportunity for us. This was Danielle and I's first time presenting at APHA, and we got to talk a lot about the work that's happening here. So we have another abstract we're also working on that we may wind up going to another conference to present about this work. And we're definitely, like I said, you know, we're passing the collection plate around. So we're doing our very best to keep this work going. And we definitely thank you. We love the work that you all are doing. We're very excited to share with anybody that will listen to us what's happening here in the great state of Michigan. I think I'm done now.
Yes, you're all set. So I just want to say again, as I get out that glare, thank you all for the work that you do. We are really just the facilitators in the process, and it's the community and the community organizations that have done the brunt, done the hard work. And so if we can act as a speaker and amplify your efforts and ensure that you all have funding, then that's what we'll do. This was a lot of information at the end. If folks have immediate questions, comments, concerns, anything that you all have for us.
I'd like to offer a comment. I'm going to put my other hat on now as the president of the NAACP branch here. And this may be a subject for future discussion with this group. You know, I get into a lot of these conversations around equity and diversity, et cetera. And of course, we know that there's sort of a marginal climate and some culture developing across the country that represents pushback against some of DEI as we talk about it. And I think it's important as we go through and continue to try to help people understand and educate them about the disparities and what needs to be done, that we have the correct talking points and that we have some ability, even if it gets down to one-on-ones, to talk about why this work is important, why the ultimate outcomes are important to the community as a whole. Because, quite frankly, there's some rooms you're going to walk into, they don't want to have the hard conversation. That diversity is not an issue, that it's something that's made up. And we see evidence of that in some states where, they're even passing legislation to outlaw even having some of the discussion. So that's not happening in Michigan, but I tell you, there are people in Michigan who don't share some of the same thoughts that we do. The more visible this work is, some of those people will surface in our communities, and I think we have to be prepared to talk about it. That's my comment.
I want to respond to your comment with absolutely. We are not oblivious to what's happening clearly across our state. Some of our councils particularly have experienced a lot more struggles in that department of talking about just the word equity than others. So we know it's a real thing. In fact, one of the sessions that Danielle and I were looking at or went to at APHA was looking at the economic impact of inequity. And so what we know to be true is that you got to have a price tag, right? It's got to be dollars and cents. People like the charts and the graphs, but until we can put the monetary value on how much more we're spending because we are doing things inequitably, it's going to be very difficult for people to attach the value to the work that we're doing. So we're trying to figure out what some of that looks like for us here at the state, but also definitely in particular communities. And I think I want to mention that it's valuable for us to have each other's backs because, again, some of our councils are facing challenges that others, quite frankly, aren't because of the political climate where they're located. And we got to stand in that gap for one another because that work is so important. And when you're facing really serious uphill challenges to get that work done, it can be demoralizing. And so a lot of the councils have mentioned today about mental health. Our mental health, the mental health of our staffs, of our teams, not just of our communities, are important because if we're not whole, we certainly can't help the next person. So I would just encourage us all to be mindful of that and stand in that gap as we continue to move forward. I anticipate there'll be a lot of those additional challenges from a political standpoint as we move forward again. So just being mindful of those pieces too, as we sort of work together to do this work. But excellent point, Terry. And I just wanted to echo those couple of pieces that I think are important.
Alton, the other thing he said, I want to make sure that we don't miss it, is he said that we need a good
toolkit.
Yeah, that is, but I want something that's short and sweet that has the great data that backs up the value of equity in this conversation. Are you guys willing to develop a tool like that?
Yeah, we're already sort of thinking about what that looks like. That's why I mentioned that, one of the things we went to at APHA was sort of how do we sort of develop that messaging. So we're definitely looking at that. That's critical for us, not just for the councils, but literally everything that comes out of our office as the Office of Equity and Minority Health. So we're definitely looking at that. I don't know how quickly we're going to be able to develop something we think we can turn back around, but we're definitely already on that train.
Okay, thank you.
Yeah, I mean, because it's a part of our everyday conversation as we're continuing to leverage for funds. So we sort of need to refine it and make it user-friendly, if you will, because we also need to be able to tailor it to multiple audiences. So
and I think the critical part of this too is I was in a meeting out at our state university here yesterday, and I closed it with these comments. We're going to have institutional leaders who will say all the right things because they're trained to, that they embrace and support closing the equity gap, eliminating the disparities, etc. but I think some of us have to hold them accountable. I mean, in other words, they have to begin to walk the talk. I had an encounter with the largest CEO of our largest healthcare institution in this community. And it was not related to the Health Equity Council, but an issue that had come up inside the organization that was a discrimination issue. And we were sitting there one-on-one, and there was a copy of the annual report for the institution sitting next to me. And I picked it up, and you go through the first 5 pages of the report. Obviously, the first page is the letter from the chairman of the board. The second page is the letter from the CEO. The third page is all the other board members on the board of directors. The fourth page is all the second lieutenants and people who report directly to the CEO. And so you get through the 4, 5, 6 pages of the book. And I said, Madam CEO, what's wrong with what I'm looking at? And she says, well, what do you mean by that? I said, when I look at the entire leadership of this institution, there is nobody who comes close to looking like me. And you're in a community that's well over 50% minority. So all of the decisions about me and about us get made by people who look like you. And it was a hard pill for her to swallow. And I quickly indicated to her, listen, I know that you can't change this overnight. You know, that you're not going to go in and terminate the board of directors tomorrow, that you're not going to go in and terminate all those people who report to you, who do good work in our community. But I tell you what, if you're not committed over the next few years to creating some change in just who is delivering services and how they deliver services, you're just blowing smoke when you sit there and tell me that you're committed to diversity, because it's not real.
Amen.
Yeah, we often say, you know, in our office that it's not about not being racist, it's about being actively anti-racist, right? So you can say all day that you're not racist, or you don't, you know, you have racist tendencies, or you don't have racist policies, but if you're not breaking down the structures that enable those things to exist, then you're part of the problem. So you know, it's definitely difficult to have those conversations. I applaud you for taking the time and making the statement in that space, because speaking truth to power is not easy, nor is it likely rewarded. So I applaud you for doing it in the space. I encourage all of us, when you have the opportunity to speak truth to power, to do so. But it is definitely not easily done. So thank you for that. We know we got a long way to go. And again, we got to be mindful that there will be some additional challenges that will come our way as we move forward, and as we go into political seasons, and as we start to see an awful lot of conversation and rhetoric that will impede our airways in the future. So we got a lot of hills to climb and challenges to overcome. But if anybody can make a difference, it's definitely the folks that we have gathered here. So this work means a lot to us. You know, me and Danielle don't do this just for the paycheck, because it ain't big dollars, y'all. So, you know, this work means a lot to us. And we definitely live it every day. And we love, you know, being able to be a part of this group that is literally actively making some change where you have the opportunity to do so. So I won't do my whole soapbox moment. I know Jason's like, that's enough. So you were right in the middle of my screen, Jason, so I couldn't help myself. Any other questions or last minute comments? We're definitely over time, so you all are free to go. Nobody has to stay unless they have a question or comment or something that they wanted us to address.
Thank you, everyone. Take care.
Thank you.
Thanks for being a good sport, Jason, while I was picking on you.
Oh,